Hello, this is Dr. Dimitrios Kostopoulos, and this is another episode of the podcast Precision in Clinical Practice, Boosting Profits and Patient Outcomes with Diagnostics. And today we have put together for you a very, very interesting podcast that promises to provide you with gems, ideas, and tips that can take your clinical practice to the next level. I hope you enjoy it. Let's listen to it. So, hello everyone. I have with me Bart MacDonald. Bart MacDonald is a very good friend, and he is a HODS member now for how many years, Bart?
4 years.
4 years. He has an amazing and ever-expanding organization in Idaho and beyond. I will ask him some questions. As a matter of fact, just before we started this, he asked me, he says, well, what questions are you going to ask me? And I said, no, I'm not telling you. I want it to be just natural. So, okay. So Bart, thank you for doing this, first of all. When you joined HODS, what made you join HODS? How come you decided to do that?
Well, that's a really good question. And actually, it's a question I've had to answer over and over to some of our providers from the standpoint that as we get somebody new on, they're like, well, I've never seen this in physical therapy before. This is phenomenal. What led you to this path, right? About four and a half years ago, I was working really closely with a sports medicine physician. And this is probably the first answer of a two-part answer. So I should tell you that. So the first part was very clinical. And I was working with a sports medicine physician here in next to one of our clinics. And he had sent me a patient with a shoulder injury that did not, in his understanding, need surgery. He did musculoskeletal ultrasound as a sports medicine physician, and I was very intrigued. What he did in this case is he set this up for me, Dimi, where he basically said, here's the image of the supraspinatus at the shoulder. And it's twice as big or as thick as what a normal tendon should be. And what I need you to do is perform physical therapy for the next 6 weeks and see if you can reduce the thickness of the supraspinatus tendon and hence avoid surgery for this patient. So as a background, this patient was an engineer by day and a drummer by night. And so a lot of this overuse type of scenario on a ride cymbal was cruising for this right shoulder. And this individual surely did not want surgery if they could avoid it. And so it was amazing. We did physical therapy, if my memory serves. This is a few years back, but we did physical therapy, I want to say for about 5 or 6 weeks, had very improved success. The patient reported, number one, I have better, I don't wake up because of shoulder pain at night. So that was a really good improvement. And we're with ASTEM and some other treatment modalities that we were utilizing, some really, really low level strengthening as far as the dosage of strengthening for physical therapy for the rotator cuff. The sports medicine doctor, based on his ultrasound, has said, I don't want heavy strengthening. I know you guys like to go to eccentrics and really load this up, but we have some deficits with this cuff. We want to be more careful than that. And I don't want to make it a full thickness tear. So I want you to be really careful. And so we followed through with that. And to make a long story short, after doing this low level physical therapy for about 4 to 6 weeks, he said, let's turn it up a notch. And as he did a follow-up ultrasound, the thickness of the supraspinatus had reduced by about 25%. And so he was like, you guys are awesome. You're doing phenomenally. Keep going, but do some strengthening because we got to really get to an end functional goal here. So we went ahead, increased the strengthening. 4 weeks later, the patient goes back for a follow-up ultrasound with a sports med doc, and it's doubled again in size. In fact, it was worse than where we started, Dean. And I about fell off my chair. I'm looking at this, and I'm just so dumbfounded because I can't figure out where as a physical therapist I've gone wrong. Yes. So really just struggled with it. Went in, talked to the sports med doctor. We had to go a different direction on this. And at the end of the day, I said, I really love this ultrasound thing that you're doing, because what it's teaching me is that as a physical therapist without eyes on the inside of the shoulder, I am treating blind. I don't know how to dose this appropriately in so many instances. Yeah, sometimes I have an MRI, but to MRI every patient is not cost effective for the patient. And it's not medically relevant for every case. So I flat out just asked him, how can I do ultrasound? He's like, well, you know, there's a very few of us sports med docs really in the country that are good at this. You've got to find a platform for education that can teach you guys how to do this. And he said, by the way, I would predict, and he's pretty good, pretty smart guy. He said, within 10 years, Bart, within 10 years, 100% of good outpatient orthopedic PT practices will be doing this on a daily basis. So get on board. So really, I had spoken with Dimi at private practice. I don't know if you remember this. This was a few years ago. And there was a small little vendor's stand. And I remember asking about ultrasound, and then you started talking to me about EMG.
Yeah.
And to be honest, I was clueless about EMG. But EMG started to spark my interest, because I recognized for testing, understanding the true presentation and pathology of my patients, and only relying on special tests, which sometimes have anywhere from sensitivity of 25% all the way to maybe 50% on a good day for these orthopedic tests. I was really treating blind, both from a spine and peripheral nerve aspect of treatment and care, as well as from a soft tissue issue with the ultrasound. And so we connected back up. I connected back up with Dimi, and basically was just begging that, how can we get this into our practice? And I got to tell you, that's the answer to, or the first part to that question. The second one really came in as Dimi, then you opened my eyes to say, hey, look, Bart, what is your number one struggle financially with the practice? And of course, I don't know any outpatient PT owner that isn't going to say, well, it's reimbursements. Our reimbursements are going down. Like, I don't know how to control this. In fact, I have very little control over this aspect of my business. The only way that I can do this and continue to legally, ethically, and provide a quality, I've got to have increased reimbursements. And honestly, it's not a thing. And Dimi said, oh, no, it is a thing. It is a thing. You just have to be able to bring diagnostics into your practice. So at the end of the day, that's my two-part answer. I had to do it because of the quality of care that we want to provide for our patients, not treating blind anymore as physical therapists. If we're really going to call ourselves doctors of physical therapy, we better be able to take for every patient that comes through our door and be able to tell the physician, this is the rehab potential. Good, very good, poor. What is the rehab potential? If you're going to spend $2,000 in my clinic in 18 visits, whatever that looks like, do I really have a professional opinion and credibility behind that with diagnostics to back that up, objective data that says I can get you better? And I know how to guide that PT plan of care to make it happen. So that's kind of quality of care married with our current scene as PTs. We need to increase our viability with increased reimbursement.
Thank you. Now, I know that you have trained some of your staff, and recently you committed actually to train more of your staff. What does this mean, the training in diagnostics and the involvement of the practice and the staff members in diagnostics? What does it mean for your staff members, and how do you use this tool to excite staff members, to create a momentum in the practice, or even, I would say, sustainability of staff?
Yeah, well, I'll tell you, being in rural Idaho, and I don't know how many people listening out there today or in the future know what this looks like, but we're stuck halfway between in Salt Lake City, which is a very big city, all the way to the north, which is basically takes us all the way to Yellowstone Park. So in the past, we've really tried to capitalize on that, Dimi, and trying to attract and retain physical therapists and good physical therapists to our practice by saying, hey, look, You can mountain bike here all summer long, spring, it's phenomenal. You can ski. We've got some of the best ski and snow to ski on in the winter, and you can do all these things, which is really natural to Idaho. But you really don't have a big city feel here. In fact, a lot of our practitioners in the past that have been attracted and stayed are people that have family here. And for a growing practice, that stunts our growth. That's not a great plan. So what we've seen as we've started the diagnostics is the easiest way is to give the therapist what they want. In other words, some therapists out there, they probably graduate from PT school. They don't want to crack a book again. They don't really want to learn and grow. They're going to do the same home exercise program with the same low back patients forever to the end of time. We're not interested in that PT. So in our practice from day one, even when we're interviewing, we introduce them to our practice by introducing diagnostics. I usually will do an ultrasound or a portion of an EMG on every single new hire potential that comes in on interview. And their response has been phenomenal. Both as they will, in fact, we had just one just the other day. I won't put his name out there, but he had interviewed with several other practices from a local university, and we needed a hire. We needed a guy that was really bought in. And he was being offered more money at a different practice with perhaps some better benefits. And he chose us associated with the opportunity to come and do diagnostics. And really, they grab onto ultrasound because ultrasound really is netter in grayscale. If I can visualize what's underneath that shoulder and that long head of biceps and what I think that should look like, and that supraspinatus and infraspinatus, and what kind of spacing and arrangement, and I can visualize that in netter for that new grad or even that long-term PT that has a lot of experience, and then turn it around and put it in grayscale, all of a sudden it's like this light bulb goes on. One of our most recent trainees, I should tell you this, you'd be thrilled, Dimi, John Goodman. He went out just 1 month ago, maybe 5 weeks ago, out to New York to do a training in ultrasound. We had done some pre-training. We do that now because Andy Good and I are good at doing some of these things, and we want to integrate it with our staff as much as possible. Sure. So John had some experience with it, went out to New York, came back, and he has averaged 7 to 8 ultrasounds per week since he's come back. That's awesome. And he just identifies, it's been awesome. He just identifies with his patients, those new patients or the patients that are not making progress, that he needs to know that we didn't do enough up front to know what we were doing. And sometimes we're still guilty of that. But often the standard of care in our practice for new and old is we use diagnostics from day one to know which way to go. And the buy-in has been great. And the longevity, of course, in this gives us a 5-year contract with these guys that I think is helpful for us in a big way.
Yeah, and even from a financial point of view, if you think that, okay, 7, 8 of these ultrasounds, they're going to take per week, they're going to take, let's say, I don't know, maybe 4 hours for the week for them to be done. And at the end of the day, for the month, they're going to yield somewhere in the neighborhood of $5,000–6,000. That is really a no-brainer. But I want to ask you about that. Now, a lot of the people who are watching this, right, and we have surveyed this, HODS has surveyed this, like the number one reason that people, before they get into HODS, when they are just looking at HODS, the number one reason they are looking at HODS is financial, because their reimbursements are very low. And we know that nationwide reimbursement in physical therapy is somewhere between 8 to 12%. That's nationwide, according to data from PPSA/PTA. So without asking you specifics about you and your practice, if the nationwide reimbursement is, let's say, somewhere 8 to 12%, somebody who joins, let's say, HODS and puts really the time and effort and applies the program as it is intended to be, what overall would be, in whatever terms you want, you can describe it, but what would be the overall, let's say, financial benefit that someone will get? I'm not asking for numbers specifically, but what would be the overall financial benefit? Would the profit margins increase? Would the revenue increase? What are the other areas where this person will realize a financial benefit and financial security for the practice?
You know, and I know that in talking in these terms, it's going to vary from practice to practice, but I can just speak in terms of our practice. Our goal as we sat down at the beginning of 2019 was we recognized that we had gone down, I want to say 6% in our profit margin in the previous year. And we had not really gone down in number of visits. In fact, we had gone up, right? And so I think this is a common story for most PTs out there. I'm doing more and getting paid less.
Because the reimbursement went down.
Yes, yeah. And so what we decided is that per unit of time, our best reimbursing activity is diagnostics, hands down. And so our next goal then became so we've got 3 clinics right now, we're just opening our 4th. And so when we looked at this, our prior model, what I would say kind of our phase 1 model, which had helped to get us started into diagnostics in the first place, was let's have just a few key people get good at this, and maybe that's good. And what we recognized is that the more knowledge that PTs have on an individual basis as a practitioner in diagnostics, whether it be EMG or ultrasound, the more they're going to use that for their patients. We knew this was true. And the more that they use it for their patients, the more that the quality of what we give to the patient goes way up and our reimbursements go up. So what we did is we said we want 100% of all of our PTs to be really attain that FMSK certification. And we want that to happen within 2 years, which means this year we need a whole lot more of our PTs trained. And now we have more of an internal mentorship follow-up because of the longevity that we've had with ultrasound and EMG here in our clinic. And so now it's really just snowballed. So when we talk about what does that mean to our practice financially, our intention, and I'll just throw this number out there because I think it's helpful for people to hear. Usually if we say, hey, we're going to open another practice, this is how we're going to beat decreasing reimbursements, is we're just going to go volume, and got to open another practice. For us in Idaho, that may cost us somewhere between $200,000 to $300,000, depending on what we're investing to do a de novo startup. Okay, and I think that's fair depending on if you're doing a really good job with your equipment and space and what that looks like. Our goal was not necessarily to do that, not to add more brick and mortar, but how could we achieve not that deficit of $200,000 to $300,000, but how can we increase it to $200,000 to $300,000 in gross revenue without increasing our overhead? And diagnostics was it. Now, I have to tell you, in the amount of patients that our particular practices see that are peripheral joint injuries, it really made sense to put our focus on ultrasound first. Now, we do quite a bit of EMG, and you'll get me talking about that, Dimi, and we'll never stop. But I do just have to tell you, our goal was to get 7 practitioners doing a minimum of 5 musculoskeletal ultrasounds a week. We knew they had the caseload to make that medically necessary. We're not asking anybody to do anything that is not correct for the patient. And that the gross profit, or gross revenue, I should say, for the year would be an additional $360,000.
Wow, awesome. That's very good. That's very good. Now, what do you see as the future being of the physical therapy profession? What challenges, like the major challenges you see for the PT profession in the future, and what role diagnostics can play to mitigate or provide solutions for those challenges?
That's a great question. And I think just going to PPS this last week, there's a lot of conversation on this, right? We want to be the doctor of physical therapy. We want to be the musculoskeletal diagnostician and specialist. We want to be a little closer to that military model for providing care. Why do we want to be that? Well, we have the expertise in that area. but the other reason is that is the most economical model, in my opinion, for the United States healthcare conundrum that we find ourselves in right now. It's out of control. Our spending is out of control. And when you start listening to our orthopedic surgeons in our area and asking them, what are some of your hardest problems? Of course, they're going to complain about reimbursements too. But one of the other things that they bring up is that they are being beat up by Blue Cross because they're being told, hey, look, you guys are ordering too many MRIs. You're too much diagnostics from the standpoint of the cost of an MRI, $2,000 or $3,000 a whack. And every patient that comes into your office that has some kind of a shoulder problem, a knee problem, an ankle problem, whatever, we're just imaging at such a high rate. And so it's been really interesting to listen to those orthopedic surgeons and some of those other sports med doctors push us as a PT practice to say, get into this because it's cost effective. Now, how do we marry those two things in kind of where does the future of PT lie? It really does align. We arrive when we essentially align our goals with recognizing who we really are with diagnostics in a cost-effective way. And that's what ultrasound and EMG provides for us that we can't get any other way. We just don't have, we've said it before, sensitivity, specificity by hands-on alone. We marry our orthopedic exam with diagnostics. And when I say that, it's not at an MRI rate. So it's saving the taxpayers, if we're talking about government payers, we're saving families, we're saving really all of our friends and neighbors thousands of dollars within our community. And the broken system, we now can be part of fixing that broken system.
Awesome.
So this really is the only way. I really feel like you're going to have two groups of PTs over the next 5 years. You're going to have the one group that has lower and lower reimbursements and becomes less and less of a credible contributor to the medical model. And then you're going to have diagnostics for PTs married in those practices that are saving medical dollars. In fact, if I can just have a little tangent, I had a gal that came in a few weeks ago. I'm presenting on this at tonight's webinar. She came in with anterior hip pain. And I did my orthopedic exam. I had a little bit of range of motion deficits at the hip. We had weakness that was about 3+ and painful at most of those motions, including really the hip flexors. Abductors were in that same group, extensors. I mean, it's kind of global. I do a scour test, and I get kind of a plus-minus on that. It's kind of painful. Do some impingement tests. That's kind of plus-minus on that, too. Ended up just going right to the ultrasound. She's got OA galore. Big, huge bone spur in that anterior capsule, just really, I mean, no wonder it hurt. The patient took one look and said, oh my goodness, PT isn't going to help me, right? And we did do a little PT as we then referred her on to the orthopedic surgeon, became really a viable part of the team as a physical therapist with an image that was super cheap compared to everything else, showed that bone spur, went back to the GP. Then I held the hand with the patient to go up there to the orthopedic surgeon, and I referred to the patient for surgery.
And your credibility level goes up there.
Oh, yes.
Yeah.
So just as an aside, there's, from a marketability standpoint, I have to tell you, Dimi, there are statements made by GPs, especially PAs and NPs, which I know there's a lot of PTs that get a lot of referrals from these guys. And as of the last 6 months, there's been 2 or 3 different groups that say we only send shoulders to superior physical therapy. Why? Because we get results and we get a diagnostic-driven plan of care so that we know we're not wasting money on PT. Awesome. We're only going to use PT when it's going to work. Awesome. So I think that really is the future of PT. And hopefully that wasn't too long, but I could probably keep going.
Look, here's the thing. Actually, I asked you the basic questions or whatever I could think of that could be useful to the people who are watching this. But, you know, if anybody wants to talk to you directly, how can they reach you? How can they contact you?
You know, you can always shoot me an email. I'll just tell you, my email address is Bart M, as in McDonald, but bartmpt@gmail.com.
Okay.
And usually I try to reserve in my schedule half hour, an hour each week just to be able to answer questions on this. Mostly because I don't know if you guys ever feel this. I've got a mother-in-law, and this is kind of funny, but she finds a product at Costco. This is funny, and she will sell it to 100% of all of her friends and neighbors, right? Does Costco give her a kickback? No. Is she making any money on that at all? Absolutely not. Now, as I'm laughing at her the other day on this, she made fun of me in the same way. She's like, well, that's that diagnostic stuff that you do for PTs the same way. Didn't you just go down to the Utah section for the Physical Therapy Association of Utah and set up a vendor booth and go and talk to people, as many people as you could about this? I'm like, yeah. Why'd you do it? Well, because I know it's the right way for the profession. This is it. And so if you're like me as another PT out there, sometimes you just get to things that you know are benefit for the patient, benefit for the practice, benefit for the medical community at large, that enable you to become who you want to be, and then you can't quit talking about it. And so that's why Dimi hasn't got an edge, a word in edgewise, is because I can't stop talking. So.
Thank you, Bart. And the truth of the matter is, and I say that to people when I talk to them on the phone, that aside from the money, the reimbursement and all that stuff, we have created here with all the HODS members around the country, we have created a movement where we are changing really the future of the physical therapy profession. And Bart is a leader in that change, in that process. So thank you so much for doing this today. And those of you who want more information, you can go to diagnostics4pt.com or ptmadeeasy.com to get more information about HODS and its products. Thank you.
All right. That's it for today. I hope you enjoyed today's podcast and that you got some gems, ideas, and tips that you can use in your clinical practice that can create a difference in the way you practice and the way you profit. I hope to see you all next week. Until then, have a wonderful week.